Sir, am I visible, sir?
रघु make it in a PPT mode, Raghu.
Yes.
Yeah. Scroll up and down.
Yes. Can I present now,
Vishal
sir?
sir, we can start,
Yeah,
sir.
please start. Please start.
Good morning, sir. I am Dr. Raghuram, final year HPB surgery, Mahatma Gandhi Hospital.
Sir, you
Today
are
I
not
am
audible, sir, Vishal sir. Just a minute. Okay. Yes, sir. Good morning, Vishal sir. Sir,
Yeah,
sir,
please start.
yes, yes, sir. Yes. Raghu, you can start now. Sir is on. Sir is online.
Yes, sir. Good morning, sir. I am Dr. Raghuram, final year MCH resident, HPB surgery in Mahatma Gandhi Hospital, Jaipur. Today I am going to present a case of 78-year male who is farmer by occupation, resident of Hanumangarh, Rajasthan, came with a chief complaints of loss of appetite since 2 months and loss of weight for 2 months. Patient coming to his history of present illness, he has complaint of loss of appetite from 2 months, which is insidious onset and a gradual increasing, for which he took Ayurvedic medication and he has no improve in his appetite. And patient has a significant weight loss over the period of 2 months. His weight loss is from previously he used to be 76 kgs, and at present weight his present weight is 59 kgs. And there is no history of abdominal pain, no history of nausea, vomiting, or abdominal distension, no history of fever, malaise, no history of jaundice, pruritus, no history of melena, hematemesis, no history of bleeding PR, no history of any constipation, loose stools, or any clay colored stools, no history of convulsions, bone pain, hemoptysis, or respiratory discomfort. He is not a hypertensive or a diabetic. No, he has no history of a coronary artery disease, cerebrovascular accident, pulmonary TB, asthma, chronic kidney disease, or any hypothyroidism. He is coming to his personal history. He is a vegetarian by diet. His sleep is adequate and undisturbed. And he has regular bowel habits. He is not a smoker, not an alcoholic, not a gutka chewer also. Coming to his family history, no history of malignancy in his family. Coming to his allergic history, he has no allergies. Can I summarize, sir?
Yes, please summarize it.
Yes, sir. Coming to the summary, patient is a 78-year-old male presenting with complaints of loss of appetite and significant weight loss without any history of jaundice, infection, or any other complaints.
Right. So this patient actually is having a non-specific generalized constitutional symptoms, right?
Yes, sir.
There are no history of any systemic complaints,
Yes,
for
sir.
example, chest or abdomen, right?
Yes.
So suppose use this patient first time in your OPD.
Yes, sir.
What will be your assessment?
Uh,
Because now most probably this patient has come to you because patient has already worked up elsewhere, and most probably he is having some kind of GI pathology or HPV pathology. That's why patient is with you,
yes, sir.
right?
Yes, sir.
So in the absence of any abdominal symptoms, because it's specifically mentioned about no history of jaundice or infection.
Yes, sir.
So I just want to ask you why you have emphasized on the history suggestive of jaundice first and history suggestive of infection in your summary.
Sir, generally we will get HBV cases, sir. So I have mentioned that jaundice or any infections. Any fever is also not there.
No, if you are right, so why specifically jaundice and infection? Do you expect any infective etiology to lead to loss of appetite and significant weight loss over a period of 2 months in this nearly 78-year-old male patient?
Any infective etiology is
Then why not
good to say, sir.
see in the summary you are mentioning specifically about the
Yes, sir.
without any means you are emphasizing more on the negative history. So given his age and significant weight loss, significant anorexia, there may
Yes,
be other negative history which may be more important or relevant and pertinent if you are focusing on the GI pathology,
yes,
right? It
yes,
may be like, for example,
yes.
any GI bleed, any anemia, negative
Uh,
history of constipation.
no history of constipation,
So
no
that would
history
be
of
a
melena.
entire long list of negative symptoms.
Yes, sir.
Got my point. But why specifically on jaundice and infection? Because you knew the diagnosis. See, the patient is with
Uh,
you. It means ki you know the diagnosis because these constitutional symptoms, patient will not come to you. Patient will go to some general physician.
yes, sir.
Got my point. Just try to understand what I am trying to convey the message,
Yes. So I
right? Because
did not add any
you can
jaundice.
simply, I think in summary, you can simply say without emphasizing on the specifically on the negative this thing jaundice and infection. Because if you start saying about the jaundice and infection, then there is a other important symptoms. Why can't it be a coronary cancer in this age group? If you are focusing on the GI part, it may be a right side colon cancer.
Yes, yes,
Got my point?
yes, understood. So, come in my summary, I won't add any jaundice or infections. I will.
Yeah, exactly. And the history part, why there is a no history of conversions? Why you have mentioned specifically on the conversion part?
I thought any brain metastasis may be causing convulsions. In that way, I have it.
Okay, so how commonly the brain metastasis present with seizures?
Actually, it will present with headache like that, sir.
Yeah, there may be many more symptoms, and it is very unlikely for a GI primary GI tumor to present with brain metastasis to begin with.
Yes,
Very unlikely, specifically when you have all other negative history.
yes.
Okay, go ahead.
Coming to the general examination, patient was examined in a well-light room. Patient was conscious oriented, moderately built, and poorly nourished. His ECOG status is 1. His BMI is 19.9 with a height of 172 centimeters and weight of 59 kgs. He's having a pulse of 90, BP 120 to 78, febrile on touch. His saturation is 96% at room air. Breath holding time is 25 seconds. There is no pallor, icterus, clubbing, cyanosis, or pedal edema. There is no left supraclavicular lymphadenopathy or any generalized lymphadenopathy. Coming to his abdominal examination, on inspection, abdomen is scaphoid, umbilicus is pushed downwards, no scar, sinus, or any dilated veins, no visible peristalsis or pulsations, hernial orifice, no visible cough impulse is present, renal angles is normal, spine is normal. On palpation, there is no local rise of temperature. There is no tenderness in any quadrant. Yeah, but a firm, non-tender epigastric mass of size 3 into 3 centimeter is palpable, which has smooth surface. Margins are not well defined, and it is non-pulsatile, which is moves in craniocaudal direction with respiration, and no finger insinuation below the rib cages. No other palpable mass is present in the abdomen. There is no splenomegaly. On percussion, dullness is seen over the mass. It is noted in continuity with the liver dullness over the right hypochondrium also. Tympanic note is present all over the abdomen. No free fluid is evidence on percussion. On auscultation, normal bowel sounds are heard. On distal rectal examination, perianal skin is normal, no fissure, fistula, or hemorrhoids. Sphincter tone is normal, yellow color staining of a gloved finger is seen. No blood or evidence of any melena, no palpable mass or nodule. Other system examination, respiratory system, bilateral air entry is equal, no added sounds. CVS and CNS are normals. Coming to the summary, can I summarize?
Just go back, please.
Yes.
Just go back on your abdominal examination.
Yes.
Next, abdominal examination. You
Uh,
mentioned some findings regarding the lump in the epigastrium.
yes. On palpation, it
Next
is
one,
found
palpation.
on palpation, epigastric
Yeah,
mass
you
is found.
just no. There are 2 points. You mentioned that it moves in a craniocaudal direction with respiration. So, do you expect side to side movement with respiration? Suppose any
No,
lump
sir.
is moving with respiration, what kind of movement you expect, side to side or craniocaudal?
Along with respiration, there will be only craniocaudal direction movements.
Right. Okay. So,
Yes.
I think you need not to add this point that it is moving in a craniocaudal direction with respiration. If you say it is moving with respiration, it is assume that it is moving in the craniocaudal direction. Now, what point is missing is that whether it is moving, it has a side to side mobility or not.
No side to
Got my
side
point.
mobilities.
Right. And second, no finger insinuation below rib cage. It is better to say no finger could not be insinuated between the lump and the costal margins, because rib cage is a very, I think it is a very big in this thing extension. Rib cage means it is a different thing.
Yes.
It is better to say it is a between the subcostal margin and the lump or mass, whatever.
Yes.
Okay, so that give you a better this thing impression whether it is continuous with some liver or no,
Yes.
right? And then dullness over the mass. Okay. So what is the liver span?
Sir, there is no hepatomegaly, sir. The liver span is normal, sir, 12 centimeters only.
Okay, right. So just summarize.
Coming to summarize, sir, 78-old male presenting with loss of appetite and weight without any history, and without any other history. On examination, there appears to be a palpable mass in the epigastric region, which is non-tender firm mass without any ascites, lymphadenopathy, or edema.
Again, I would
Is
like to
differential.
mention this thing that there is no need to add this thing palpable mass. Got my point. Is it possible that some mass is visible and it is not palpable? If you have described a mass, it means on examination, it means it was palpable.
Yes, it is
And
palpable. So
what is
on inspection, it is
yeah,
not so.
right? So there is a mass basically.
Yes.
Now the question arises: what is the organ of origin of this mass, and what do you think? Is it it looks like a benign or it looks like malignant?
Considering his history, it looks malignant, sir.
Mm-hmm.
Considering his history, it looks malignant. It is an epigastric mass. We will consider malignancy in the organs in that region. Maybe it might be arising from the stomach or left lobe of liver,
Mm-hmm.
or any aorta or any retroperitoneal lymph nodes. We will think of any malignancy in those regions.
So there are 2 points. First, you said stomach, then liver, then you said aorta and retroperitoneal lymph nodes,
Yes.
right? So on examination, what is the most important point that goes against retroperitoneal or aortic lesion?
On palpation, there is no pulsatility. So
Most important,
no pulsations.
most important. See, you mentioned it is moving with the respiration. Do you expect any retroperitoneal mass to move with the respiration?
No, sir. No, sir. It won't
Right.
move. Yes.
Specifically, you are saying aorta and retroperitoneal lymph nodes. You don't expect retroperitoneal lymph nodes that are too large to get palpable on examination, and then they move with the respiration,
They won't.
right? So I think the aortic lesion or the retroperitoneal neural mass, they are out of question.
Yes.
based on your examination findings. Then comes the liver and the stomach. So gastric mass, which is this much large that you are able to palpate it, and then patient had significant weight loss, significant anorexia. Do you expect any other presentation? So do you expect such mass to be gastric without any other complaints?
Sir, without complaints of early satiety, vomitings, any history of
Mhm.
hematemesis, uh, without any features of gastric outlet obstruction, I won't. This might not be gastric mass also. So,
Right. On examination, there is no pallor, right? So patient is
mm,
not anemic. There
not
is no
any.
history of pain. There is no history of blood transfusion, right?
Yes.
So it is very unlikely that it is something luminal
Yes.
because such a large mass which is palpable, right? And if it is arising from stomach, there must be some other features, early satiety,
Early.
maybe nausea, maybe vomiting, GI bleed, right? Anemia. So those all symptoms are absent. All
Yes.
complaints are absent. So
Yes.
unlikely that it is arising from the stomach. Then what is left is
Liver, sir. Left lobe of liver.
right. So because it is in the epigastrium, you mentioned in the epigastrium.
Yes.
Okay. Anything else? No, no other differential diagnosis. So it appears to be a malignant mass, which is most probably arising from the liver,
Liver, sir.
right?
If we
Right.
want to keep any differential diagnosis, sir,
Mm-hmm.
there may be pseudocyst of pancreas also, which may be appearing like this. But there is no history of any acute pancreatitis or abdominal pain. So that was
Why
not.
pseudosis? It is irregular, it is by 3, it is moving with the respiration. And the pseudocyst,
Yes, yes, there will not be pseudocyst also. It will not be pseudocyst.
it is irregular surface. No? You mentioned, I think, it
Uh,
might be some cystic neoplasm of the pancreas, but
I,
that should not move with the respiration.
yes, sir.
Okay. Dr. Nagar, do you think anything else can be added?
No, sir. Okay, sir.
Okay. Please go ahead with the approach. How will you approach this patient?
First, I will get a routine blood test, sir. I will go with
Mhm.
CBC, liver function test, renal function test. Uh, I will get a his evaluation also, sir. His viral markers also. I will go forward, sir. After that, I will go forward accordingly, sir. As the mass is appearing from liver, after seeing creatinine, I will order for triple phase CECT also, sir.
You will not get ultrasound at this stage.
Yes, sir. I will get an ultrasound abdomen also. First imaging, I will go for ultrasound abdomen, sir.
Yeah, I think at this stage, the approach to the patient is not like in a sequence. It's specifically for your blood test in the initial ultrasound, right? See, clinically he is stable. There is no pallor, right? There is no melena, there is no vomiting. Patient is otherwise stable.
Yes.
Only thing is there is a lump. You want to confirm the organ of origin of that mass and the nature.
Yes.
Got my
Yes.
point. And given his age, significant weight loss, significant anorexia, okay, it appears to be a malignant.
Yes, sir.
Whether it is a primary mass or it is a secondary, we don't know. So I think you can begin with the ultrasound at the same time you get the blood investigations. Rather than you wait for the blood investigation to come and then go ahead with the ultrasound and then with the CT scan like that.
Yes.
Right. So what are the investigations done so far? Blood investigation, you mentioned CBC. So what is the CBC and what is the interpretation?
Yes. Coming to his blood test, sir, his CBC is within normal limits, sir. His renal function test is also within normal limits. Creatinine is high normal value. Uh, Electrolytes are normal. Only thing is his coming to his liver function test, his ALP is on high normal, more than high normal range. High normal is 30 to 140. ALP is 164, and his OT is AST is also elevated. SGOT is elevated, 134. It is and his rest all are normal, and PTNR is normal, and HbSAg is reactive, and HIV, HCV are non-reactive.
Okay. So how can you explain this positive hepatitis B status? Surface antigen is positive. What
Yes.
could be the reason?
So HbSAg surface antigen is positive, sir. Means patient is having a chronic HBV viral infection, sir. And because of the viral infection,
In terms of source, the cause of this infection, there must be some reason for patient to have this infection. No?
any family members might have be having this infection, sir. HbSAg.
So now you want to go back and ask relevant family history or personal history in the context of this positive hepatitis B surface antigen status.
I will ask them, sir, if any home family people is having any HbSAg. Previously, anyone is under medication.
Which family member do you think is the most important?
First contact is with the wife, sir. I will start with his wife, and later his children, grandchildren.
Right. Anything else?
There are no. He might be having any cirrhosis features also, but his liver functions are normal. Only the raised ALP showing some little obstruction within the biliary tract.
In terms of the needle exposure,
Sir,
blood
co- uh,
transfusion, needle exposure, any hospitalization,
he
right?
has a
IV
he,
administration, unprotected sexual exposure, kind of thing.
uh, he has no history of
Right.
no history of any previous admissions.
So basically, on investigation, on blood investigation so far, only alphos is raised and your the
HbSAg
hepatitis
is
B
reactive.
marker positive status there, right? Otherwise, liver function is more or less maintained
Normal.
except AST, which is, I think, nearly two,
Fine.
3 times or 4 times raised,
Yes,
right? What next?
we will go with ultrasound abdomen, sir, after this.
Okay.
Coming to his ultrasound abdomen, sir, his liver is normal in size, outline, and parenchymal layer texture, and there's a heterogeneous mass of 10.2 into 7.6 centimeters in the left lobe. Uh, Gallbladder is normal. Intra and extrahepatic biliary radicals are not dilated. CBD, portal vein, pancreas, and spleen appears normal. And there is a impression there is a SOL of a liver, and there is an enlarged prostate. So there is a heterogeneous mass within the liver, sir. I will go for a triple phase CECT abdomen.
Anything else you want to get in blood investigation at this stage?
At this stage, sir, as there is a heterogeneous mass within the liver, considering his malignancy, we will go for alpha fetoprotein test, PAVKA levels, and CA99 if possible. So those blood tests I will do, sir, to consider a malignancy.
CA? No.
Sir, and
CA? Carcinoembryonic antigen?
yes, I will do that also, sir. This might be a colonic malignancy with the liver mets. I will do that also. CA
Okay.
also. And
So next we want to get CT scan. CT scan of what? Abdomen, thorax, both,
triple
or
phase
only
C.
abdomen?
I will go for a triple phase CECT of abdomen, sir. First.
Mm-hmm. Okay.
Uh,
What are the findings?
yes. Coming to his CT of whole abdomen, sir, there is a presence of solitary heterogeneous attenuation in the. Sir, can I go with imaging first, sir?
Yeah. You
Yes.
describe on the images.
And this is not clear. Why? Sir, I will show this in another format, sir. Can you give 1 minute, sir? Hello.
Okay.
Nice. तो ये वीडियो कैसे दिखाना है? शेयर filter Dropbox website URL
आपका वीडियो कहाँ है?
हम्म नहीं ये व्हाट्सएप में है, ये वीडियोस दिखाना है।
तो स्क्रीन शेयर है ना?
स्क्रीन शेयर में नहीं दिखा रहा है, वो मेरे को समझ में नहीं आ रहा है। ये शेयर है, शेयर का फोटोज में जाओ क्या?
नहीं
हाँ photo, let me go through the photos. Oh, it is not in photos.
नहीं एक मिनट सही है। व्हाट्सएप पर
WhatsApp खोलो। wait. अच्छा, you can go through this one.
इसमें नहीं है व्हाट्सएप पर।
WhatsApp खोलो, हाँ खोल लिया।
हाँ है
हाँ इधर है तो। ले नहीं, ले ले ले
क्या नहीं होता है?
do one thing. Go to do one thing. Do you have your laptop? हाँ, मैं आपको खोल रहा हूँ, मैं पीपीटी भेज।
What is the problem, Raghu?
This is not playing, sir. 1 minute, sir. I am opening in another laptop.
You are using your
iPad, sir.
huh?
I am using my iPad, sir. I am opening in Gautam's laptop now. 1 minute, sir.
The iPad usually this doesn't run through because the iPad don't have this Microsoft another software, PPT softwares.
Yes. 1 minute, sir. I am opening Gautam's laptop.
It will not work in Gautam's because we have to make him another again this
Co-host.
co-host. Vishal sir, can we have a discussion because the images are having some issues
No
with images.
problem. He can show the images, not necessarily to see the
Okay,
entire
sir.
this thing.
Yeah. So try to do early so show the images.
Yes.
Gautam.
Yes.
And after connection, just say me hello. I'll make you co-host. Which one laptop is we are using for this images, videos? Gautam or Raghu?
Sir, please make Gautam co-host, sir.
JST MGMCH. I'll ask. No.
JST. Co-host one.
Vishal sir, just I want to add something. Vishal sir.
Hello, Dr. Nagar.
Yes, sir. The most common mode of hepatitis B transmission is a perinatal transmission. It's usually mother to child, sir. And the remaining the way the IV injection, blood transfusions are the less important, less chances of transmission as there.
Yeah,
So I
agreed.
think
But given his age, na 78.
yes, but the age, this yes, I want to add the age. Age is against this thing because if the patient has developed Hep B very early, most probably
Right.
he has had developed this Hep B related complications very early, sir.
Right. And then I think he might be having some minor symptoms that he ignored and he continued to have this infection. So we need to work up on that line also,
Yes, sir. Yes, sir.
the hepatitis B part, right?
Yes.
So images, can we see the images or
Yeah, just we can just. I have
at
asked.
least he can
Asked
describe, at least he can describe. No, at least he can describe now. On the
Raghu.
slides he can
Raghu,
describe
you can
the
describe.
findings on CT scan.
Yes, sir.
Yeah, and just we'll see the images again when the Gotham makes them ready.
Yes.
So you describe the CT finding, and
Yes,
whenever
sir.
those images are available, then we can review. At least
Now
we
you are
can
a
take
co-host.
some
So
time.
yeah, he is co-host now. Now share the screen. Gautam, you are
Yes.
co-host now.
Uh, this is a full screen. Full screen. Full screen. So can you see the full screen, sir? Now?
Yeah, please go ahead.
Yes. This is the arterial phase of CT, sir. Contrast enhancer CT with arterial phase with aorta enhancement. In this, when we are there is a arterial phase enhancing space occupying lesion in the left lobe of the liver, which is compressing the lesser curvature of stomach also, and it is extending up to the and pyloric region also, sir. And it looks to be it is supplied by left hepatic artery only. And I will show portal phase, sir.
Wait in this arterial phase. So
Yes, sir.
this is in the left lobe, right? And you
Yes,
mentioned
sir.
that it is supplied
Left
from the
lobe.
left gastric artery, right?
Yes.
So what are the other
Yes.
important things that you want to see in this arterial phase? Other important findings, whether normal or abnormal, which may be relevant for the surgical planning.
Mm. Yes, sir. Any other lesions within the liver other than this left lobe?
There are
And
none, I think. है ना? You cannot see.
no other lesions are visible, sir.
Right. Anything else?
And, uh,
See, it is the arterial anatomy, na?
arterial enhancement, sir. Yes.
Because in the arterial phase, whether this is a replaced left hepatic or accessory, right? Or it is just a normal course,
It looks like it is
right? So it
this
is
is
better
common
to
hepatic artery and proper hepatic
exactly
right and left only, sir.
right. So it is better to see and comment on that aspect also because besides lesion, when you are going for the surgery for surgical planning, okay, such arterial anatomy assessment is very important, and that can be
Yes.
seen on the arterial phase itself.
Yes.
Okay.
Can I go to portal venous phase, sir? Coming to his portal venous phase, sir, there is a washout of the arterial phase enhancement, and it is all near to the left portal vein branches, extending up to the left portal vein branches without any thrombus in the portal vein. Sir, am I audible, sir? Hello.
Yeah, you are audible.
Yes. There is no thrombus in the portal vein, and no collaterals are also seen, sir, in the perigastric region or any splenic, no splenomegaly also. And coming to the hepatic venous phase, the mass the mass is nearer to the left hepatic vein, and it is away from the middle hepatic and right hepatic veins.
Okay.
Can I go to impression, sir?
Anything else you want to comment on
There is
the
no
all the
thrombus.
phases? Anything else you want to comment on?
There is no thrombus within the
There is no
hepatic veins.
thrombus in the portal vein, right? It is away from the hepatic vein. Hepatic, this arterial anatomy is otherwise normal, right? And no lymph
Yes.
nodes, no lesion in any other part of the liver.
No lymph nodes in the lesser mental regions. No
And no
lymph
obvious
nodes.
distant metastasis, right?
No
So, what is
obvious
the location of this past lesion?
location is in the
It is
segment 2
confined to only
and
the segment 2-3 or left atrial
segment 2
section, right?
segment 2-3 of livers. So it is
So, it is
here.
not
It is showing segment 2-3 of
involving
livers.
segment 4B.
Yes, it is involved in segment 4 also,
Okay,
in the upper part, segment 4A mostly. Yes.
okay. And there is no ascites, right? No
There
peritoneal
is
or orbital deposits.
no
So, what
ascites,
is your
sir. No.
next plan?
Next slide, that is the impression, sir.
Mm-hmm.
Coming to the impression of the CT, there is a presence of solitary heterogeneous attenuated solid liver SOL in left lobe of liver, involving segment 2 and 3, with surrounding hepatic parenchyma well demarcated, exophatic component in left perihepatic space, and indenting on stomach. Flat planes are remotely preserved. The size of the lesion is 14 into 10 into 8 centimeters. And enhancement, non-contrast scan. There is isodens with few irregular hypodense areas. Arterial phase, there is evidence of hypervascularity and neovascularity. Portovenous phase, there is mild washout, and delayed phase, there is evidence of capsular enhancement in delayed phase. The left hepatic vein is splayed, and compressed by the mass. Right and middle hepatic veins are normal in course. The lesion is primarily supplied by left hepatic artery. There is no aberrant or accessory hepatic arteries. Liver size of 15 centimeters. Portal vein branches are normal. No IHBRD. No focal lesion. Suprahepatic, infrahepatic IVC are normal. Pancreas, spleen, gallbladder are normal. CBD is not dilated.
And there are no features suggestive of CLD, chronic liver disease, right?
There is no feature suggestive of CLD suggested.
At least on the CT scan, right? So, what is the interpretation final?
Final interpretation: it is a left lobe liver mass, sir. It is arterial enhancement. It is suggestive of hepatocellular carcinoma of left lobe of liver, and there is no portal vein thrombosis or any other lymph nodes with cirrhosis features within the liver or any other lymphadenopathy.
Right. So, what is your next plan?
Okay, next plans are we will go with AFP levels, PIVCA levels, and we will get it is a large lesion, we will go for a PET CT to see are there any metastasis.
So what are the indication of PET CT scan with reference to size of the lesion? What is the current, is there any current guideline or recommendation that you have to get the CT scan with reference to size, any specific size cutoff?
No, sir, no specific size, sir. We are getting because if it is, it looks resectable without any portal vein thrombus or any lymphadenopathy.
No, it appears to
No,
be resectable. There is no portal vein thrombosis. It is mostly confined to left lateral. Some part is there in the segment 4. No apparent sign of distant metastasis. So, what is the AFP level? So, this is
uh,
typical of primary. You don't think this could be a metastatic lesion, right?
yes, sir.
So, what are the first of all the tumor markers?
Uh,
AFP,
liver
CEA, CA 19.9. What are those marker level?
Your liver markers of the patient, sir, AFP level is normal, sir. PUK is elevated. It is 500, sir, value.
Okay.
So it's more, it looks like a hepatocellular carcinoma, sir. Considering his age and
Mhm.
size of the tumor, if we want to, we can resect. So to do a resection, we will see any other systemic metastasis.
So, why don't you
So
just get
we
a
will.
CT scan chest? So, what are the current indications for PET CT scan in SCC?
Yes, large lesion which is not transplantable can be planned for resection.
Large again, see, large is a very subjective term.
Outside Milan criteria.
So this must be some specific size cutoff, no?
Yes.
So outside Milan, all outside Milan, they will go for, matlab, you consider them as a non-transplant candidate and then go ahead with a PET CT scan.
If it is a resectable, we
Mhm.
will plan for a PET CT scan.
Okay, and if it is resectable and within Milan criteria, then you will go ahead with the transplant. Then again, you will go for PET CT scan before you consider transplant, isn't it?
Sir,
Because if
actually,
you want to go ahead with the resection after a PET CT scan, just to rule out metastasis before resection, then you need to get PET CT scan before transplant as well.
yes, sir. We should get a PET CT before transplant as well, sir.
Right. So if you are thinking of surgical management, whether it is a resection or transplant, then you need to get PET CT scan in all the cases. In all the cases where you are planning surgical management, whether transplant or this thing. So then where comes the size criteria? If it is a small size fitting within Milan criteria, you are going for the transplant. Then again, you will get PET CT scan. If it is large size beyond Milan criteria and you are going for a section, then again you will get PET CT scan.
Yes, sir. Only for staging PET CT was used, sir.
So why not
Extra.
this CT scan chest with CT abdomen and pelvis for the staging purpose?
We might miss some systemic metastasis into the brain,
So what are the
bony
limitation of PET CT scan?
FDG activity uptake will be there in the during inflammation, any infections. Otherwise,
Mhm. And
the uptake
with reference to
uptake
size,
will limit the inflammation.
are they very much sensitive for a small lesion, less than 1 centimeter?
They are not sensitive for small lesions.
Are they sensitive for peritoneal metastasis? Are they sensitive for pleural deposits, small pleural deposits?
They are not sensitive, sir. For small pleural deposits, they may not be visible, sir.
Right, exactly.
Yes.
Okay. So
So
what is your next planning? You got the PET
uh,
CT scan and that is negative for distant metastasis. Then
we will and we will do systemic evaluation also, sir. How is his cardiac status, pulmonary status, and whether he is fit for surgery, and we will evaluate and we will plan for a resection, sir.
What resection are you planning? Patient is fit for
We
surgery.
we will
Okay, we
plan
will
for
just
left.
bind up in we will just bind up in 2 minutes, right?
Yes, sir. We will
Already
plan for
crossed
left
10
hepatectomy.
time.
We will plan for left hepatectomy, sir. Oh,
Okay. So before left hepatectomy, do you want to assess anything else besides the general fitness?
his HBV DNA levels we will also see, and we will whether we have to start the medication about the HbSAg. We will check once, sir,
Do you
before
want to
surgery.
assess the do you want to assess the quantity and quality of remaining liver
We
given
will
his
go for volumetry also, sir.
hepatitis B positive status?
Yeah, we will go for volumetry. What is the large, how much will be left after a surgery? If it is not so, we will go for augmentation of future liver remnant with the portal vein embolization, or
Do you
we
think
will.
that would be required in this patient? You have seen the CT scan. What is the
Yes,
possibility that this patient will require FLR augmentation?
sir. For a normal liver, it should be
What
at
are the
least
chances?
for a normal liver, it should be 20 to 30%, sir. Uh, future liver should be future FLR should be
Do you
considering
think
his
in this patient the FLR would be less than that, especially
no,
in
sir.
the lesion in the left lobe we were planning hepatectomy? So volume wise, I don't think there would be a compromise. Only thing is
Yes,
that his functional status, which is preserved uh, as of yet, right? But do you
yes.
want to get the fibroscan
We will
or
get
no?
a fibroscan. Yes, sir. We will get a fibroscan as the patient is HbSAg positive. We will see whether the liver stiffness is increased with any how what is the liver stiffness index. We will evaluate, sir, before operating.
So will that change your management?
No, sir. That we should see if the patient has a
Mhm.
cirrhotic liver. The remnant liver should at least be 40% of the total liver volume. We will
Right.
consider
And
that thing.
mhm. And will you consider staging laparoscopy before proceeding to open resection, or you do want
Uh,
to continue with the directly with the resection without any staging or diagnostic laparoscopy?
uh,
Any
I
indication, any uh, benefit?
I will go for staging laparoscopy, sir, to see any metastasis, to any invisible metastasis to the right lobe, which
What would
will
be
be
more
seen on
important than metastasis?
multifocal HCC.
More important than that, again, the liver part, na, remaining liver, because he is hepatitis B positive. Liver function may be preserved, but it may be a grossly cirrhotic liver,
Yes, sir.
right? So
We on the
besides the distant metastasis, the quality of remaining liver can be very well seen on the staging laparoscopy.
yes, sir.
So I think Dr. Nagar, we can wind up. Maybe some other points which we could not cover, maybe discuss on your group, right?
Yes, sir. Yes, sir. Yes, sir. Thank you, sir. This is
Okay,
very
okay,
rightly
right.
said by sir. It's a very when we are having the patient of left lobe matlab liver mass, so we always try to establish the patient is having cirrhosis or portal hypertension or not. And the sir, as I discussed, Milan criteria, when the patient we have a HCC in the normal liver background, we'll never talk about the liver transplant in this patient. In the normal background liver, we always try to resect the liver. Okay, Raghu, what you were
Yes,
saying
sir.
in the okay, and the liver quality we always do a fibroscan. So you should have told this initially, sir. I will check the liver quality with the help of fibroscan. And I will
Yes,
also rule out the signs of portal hypertension, like you have seen in the CT scan images, ultrasound, no splenomegaly. And if you have doubt, then maybe you can plan for the upper endoscopy also to see the varices also.
yes, sir.
Okay. Thank
Yes.
you, Vishal sir. Thank you for the
Right.
moderating the
Okay. Thank
presentation.
you.
Yes.
Thank
Yes.
Thank you, sir. Thank you, sir.